Welcome to MedPractice MadePerfect, brought to you by Practice First Medical Management Solutions. My name's Tom Maher, and I'll be your host. So today our topic is going to be the various changes that have occurred since the end of the public health emergency. So as everyone recalls, CMS put together all sorts of guidelines at the beginning of the pandemic, towards the beginning of the pandemic, instituting many changes as far as coding, billing, and credentialing goes. The rule of thumb to bear in mind is that anything that you changed towards the beginning of the pandemic from a billing, coding, credentialing standpoint, you really should take a look at to make sure that it is still valid. So today, I wanted to run through kind of on a summary, and there's quite a bit of detail as well. By no means is this an all-inclusive list of everything that you need to be made aware of, but I tried to pick out the most important points under each area. So regarding testing for COVID, people with traditional Medicare can continue to receive COVID-19 PCR and antigen tests with no cost sharing when the test is ordered by a physician and certain other healthcare providers and performed by a laboratory. A little bit different for private insurance coverages. You really should check with your local carriers to see if there may be cost sharing, prior authorization, or other forms of medical management that may be required. States are required, for Medicaid and CHIP coverage to provide, these services without cost sharing for vaccines, testing, and treatments through September 30th, 2024. So regarding vaccinations, there's no out-of-pocket costs after the end of the PHE for vaccinations for Medicare patients, and CMS will continue to pay approximately $40 per dose for administering those vaccines. By 1/1/24, that rate should drop to their customary rate for vaccines, which will be in the neighborhood of $30. Most forms of private health insurance, including ACA plans, will continue to cover the vaccine without cost share for the time being. So regarding treatments, Medicare will continue to cover treatments for patients with COVID-19 once the public health emergency ends. And the end date of the PHE was designated as May 11th, 2023. So effective 1/1/24 for drugs and biologicals with respect to COVID, CMS will pay for the treatment or for the drugs and biologics for COVID-19 as they would for other complex biological products. So we're getting into a period where things will start to normalize more so in 2024. The other big area where there were many changes made once the pandemic started was, of course, the telehealth area. So, I'll hit a few highlights, as it relates to telehealth. So, Medicare patients can continue to see providers virtually using telehealth through December 31st, 24. So at this point, we've got about another year and a half worth of that they've committed to. As far as there's no geographic area restrictions in the United States, including from their homes. So Medicare patients can access from their home as they were before. One of the things to bear in mind is that place of service O2 is used for telehealth services. This site of service designation will allow the provider to receive the complete allowance for payment instead of being allowed at the lower facility rate. That waiver continues through 12/31/24. So there's a certain number of telehealth visits. Actually, there's quite a few of them where CMS is going to continue to allow a telephone-only visit rather than it having to be telephone and video. Some of the things that are covered, under the telephone only are, psychiatric evals, behavioral type stuff, smoking cessation, speech therapy. There's really a whole host of those things. You can go to Medicare's website, CMS's website, and get a full list of those telehealth services that could be provided by phone. So, as far as your local carriers go, those rules are all over the place, and I would suggest for sure that you go to your local carrier and make sure that you follow whatever their protocols are. So the other thing to keep in mind regarding the telehealth is there's so many aspects to this form of care that make sure that you check related to your specialty to check for changes that are happening for 2024 and 25. So, there's all sorts of different rules and so forth for inpatient consults, and the list really goes on and on. So the next thing that I wanted to touch on here is credentialing matters related to Medicare enrollment. So throughout the pandemic, CMS really expedited any pending and new Medicare enrollment applications from physicians or other healthcare providers and suppliers. Since the pandemic has ended, they are going to revert back to their normal processing times. I think the normal processing times, if I remember, were somewhere in the neighborhood of 60 to 90 days for enrollment applications. Our local Medicare carrier here, NGS, effective June 12th of 23, disconnected their PHE hotlines, and all the provider enrollment and revalidation flexibilities came to a screeching halt. So something to keep in mind, we're going to have to allow a little bit more time for your applications for new providers. As far as physician licensure and practice location flexibility, CMS waived Medicare's requirement that a physician be licensed in the state in which the physician was practicing if certain requirements were met, allowing licensed physicians to bill Medicare for services provided in one or more states beyond their state of enrollment. One thing to bear in mind, though, is this waiver did not waive state or local government licensure requirements. So, CMS is going to continue to defer to state law in this regard. So, before, if the state allowed it, you didn't have to have a license there to practice, basically. So, something to bear in mind. On a related note, CMS permitted physicians and other practitioners to provide telehealth services from their own homes without reporting their home addresses in their Medicare enrollments. So accordingly, providers could continue to bill from their enrolled location despite actually providing services from home. Since the PHE is ended, physicians and other providers must report their home address on their Medicaid enrollment forms if that location is where they're going to continue to provide those services from. So that's a little subtle change that could be problematic for you if you don't have your credentialing. So the next thing I want to talk about is related workforce related issues. So these things have to do with supervision, and some of those rules were relaxed during the pandemic. So effective next calendar year, January 1st, 24, the regulatory definition of direct supervision returns to the pre-pandemic rules, requiring that the supervising physician or practitioner must be immediately available to furnish assistance and direction. The virtual presence of the supervising or practitioner will no longer be permitted. So That's a pretty important change. Secondly, the general level of supervision for non-surgical extended duration therapeutic services enabled through the pandemic has been made a permanent policy. The prior incident to physician service rules will be reinstated 1/1/24. The beneficiary informed consent to receive services furnished by auxiliary personnel will also return to the pre-pandemic rules on 1/1/24. Another factor here is NPs, clinical nurse specialists, certified midwives, PAs, CRNAs are permanently allowed to supervise diagnostic tests as authorized under state law and licensure. These providers are required to continue the statutory relationships with supervising or collaborating physicians. There are a number of changes in this area, and the things that I've talked about here are just the top level changes. So, a few other things here administratively. The blanket waivers applied to certain provisions of the Stark Law that were, those things are now terminated at the end of Public Health Emergency 5/11/23. So, physicians and entities, must comply with all provisions of the Stark Law once again. So that's very important. There are clinical restrictions in NCDs and LCDs on respiratory-related devices, home infusion pumps, and home anticoagulation therapy. This also returns to the pre-PHE enforcement. The signature and proof of delivery requirements have been reinstated for Part B drugs and DME. This is an interesting little point here on MIPS. Individual MIPS eligible clinicians who do not submit any MIPS data by the deadline of March 31st, 2022 will have all 4 MIPS performance categories reweighted to 0% and receive a neutral payment adjustment in the 2023 payment year. So please keep that in mind. This automatic policy doesn't apply to groups, virtual groups, or advanced payment model. So something that you need to keep in mind. There's a few other waivers here that I'll kind of wrap up and discuss. The waiver of the Medicare 3-day qualifying hospital stay requirement prior to a Medicare covered SNF stay will no longer be in effect for the Medicare fee-for-service program since the pandemic ended. Secondly, CMS is exercising enforcement discretion to allow teaching physicians at all teaching settings to be present virtually through audio, video, real-time communication technology for purposes of billing under the PFS services they furnish involving resident physicians through December 31st, 2023. So you see, like in some of these cases where they're still allowing a little bit of leniency for at least a short time for people to kind of ease their way, back to the way things were, if you will. So regarding the Medicare physician supervision requirements, CMS has temporarily modified the regulatory definition of direct supervision, which requires the supervising physician or practitioner to be immediately available. Okay, we did run through that, and that's good through December 31st, 23. The last item I'll touch on here is the locum tenens rule. So the locum tenens rules were designed initially as a way for to bill under a provider who may be on an extended vacation, disability, etc., to have another physician come in from the outside and use that provider's number to bill under. So, there were changes to this during the pandemic, and, I'll kind of run through here, what they're looking at now. So, CMS has modified the 60-day limit, to allow a physician or physical therapist, for that matter, to use the same substitute physician or PT for the entire time he or she is unavailable to provide services during the COVID-19 emergency, plus an additional period of no more than 60 continuous days after the PHE expires. Okay, so that takes you through June, July 12th of 23. So on the 61st day, so the 13th, after the public health emergency ends, the regular physician or PT must use a different substitute or return to work in his or her practice for at least 1 day in order to reset the 60-day clock. So, the modified timetable here applies to both types of substitute billing agreements under Medicare fee-for-service. For example, reciprocal billing arrangements and fee-for-time compensation arrangements, formerly known as locum tenens. So, again, these are, some of the details and a little bit of a higher level view. I would encourage you to definitely speak with your local carriers, stay on top of what CMS is providing, along with Medicaid as well. So they're all valuable resources for any very specific question that you have. As always, if you have any specific questions, regarding this podcast, you can reach me at tom@pracfirst.com. And I can be reached at 716-861-1199. Thanks for joining us today. Hope you enjoyed the episode. Thanks for listening to MedPractice Made Perfect.